Okay. Alrighty, cool. So we're still going to start with anatomy. So as I said, year 2 is really nice because everything you're going to learn is going to be split into all your systems. So your first one is resp, and it's a really nice system to start with because anatomy for this is really easy compared to some of your later systems. So this is kind of like a 2-week kind of chill period. It's like an easing into the course kind of thing. But I know that like some people do find it a bit difficult. Definitely physiology is a bit strange for this, but it's okay to be kind of lost. And hopefully this will help you like navigate your way through the lungs a little bit more. So anatomy of the lung, you've got 2 of them. You've got a right one and you've got a left one as well. They sit either side of the mediastinum, so that's what you covered last year. So as a result, your mediastinum is just like the part of your thoracic cavity. So it's containing a bunch of things like your heart, your thymus, portions of your like esophagus, your trachea as well. Your mediastinum is also divided into like the anterior, middle, posterior, and superior regions. We'll go through those a bit later, but I believe you guys covered it with the heart last year. So the main function of your lungs is basically to oxygenate your blood. So you do this by basically bringing in air that you inspire, so air on inspiration, and you bring it in close relation to your venous blood so that you can basically have gas exchange. So the oxygen can go into the venous blood. Venous blood is usually deoxygenated, so it's going to be oxygenated in this process. This process that we just talked about is going to occur in this thing called pulmonary capillaries. We'll go through what that is later, but essentially it's just a section of blood vessels. So you'll notice on this diagram that you've got a left and right lung, and the right lung seems a little bit big. It means it's a bit hard to see, but the right lung is bigger than the left. And that's basically because your heart is sitting slightly basically towards the left. So your left lung has to accommodate for the heart. So it gets squished up a little. So this also means that your right lung is only going to have 3 lobes and your left lung will have 2. So the right lung is bigger, so it's split into 3. The left one has 2. All right, you've also got a couple of key landmarks. So you've got the apex, which is basically the top, as you can probably imagine. So this is the superior end of the lung. It will ascend above the first rib. So it actually comes above the first rib. And sometimes it also goes all the way to the roof of the neck. You've also got the base, which is at the bottom, and it's a concave structure. It's opposite the apex, and it basically is just there to accommodate for the dome of this diaphragm. So this is the diaphragm over there, and you've got this concave structure that accommodates for it. So this is really important because as a pleural effusion, which is basically when you get the buildup of fluid around the lungs, this is where fluid is going to go. It's going to go all the way to the base. So when you see like a chest x-ray, you're going to see the fluid around there. And that's why we get like blunting of the costode diaphragmatic angle, which you may have talked about last year. Okay, so we've also got the mediastinal surface. So that's just related to the mediastinum, which is like in the middle. So it's that yellow thing over there. And you've also got like the costal surface, which is basically this large and smooth like surface that's facing the ribs. And then you also have the diaphragmatic surface, once again, that's facing the diaphragm. So really interestingly, your right, as you can imagine, or you can see from here, your right is actually higher up than your left. And that's the reason is because you've got your liver on the right-hand side. So your liver is just pushing up that lung. And so that's why your right is going to be just slightly higher than the left. We've also got 3 borders, which are your anterior, inferior, and posterior borders, but no one really cares about them. So you don't really need to worry about them either. Okay, so the lungs are attached to the mediastinum basically by the root of the lung, by the root. Your lung root is basically going to contain a couple of things. So it contains your bronchi, it contains pulmonary arteries, your pulmonary vein. So you've got a superior, inferior pulmonary vein. It contains both of them. It also contains the main bronchus, and it contains nerves and lymphatics. So all of the structures that form the root of the lung pass through what we call the hilum. So the hilum is what allows for these structures to actually enter and exit the lungs. So it's a really important, they really highlighted in anatomy as well, but it's really important to know the distinction between what the hilum is and what the root of the lung is. So the root of the lung is basically just like It's just like it connects the medial surface of the lung with the mediastinum, and it's the actual group of structures that are entering and leaving the lung. And all these structures are going to be surrounded by a tubular sheet that is derived from the mediastinal pleura that we remember that is basically lining that inner surface over here. So the hilum, on the other hand, it's not actually the structures, it's the sites. It's just like the area where things are entering and exiting. And it's that area associated with the lung. So that's the distinction between the root and the hilum. All right, that's pretty much it. Okay, so something that we do need to know in a bit of detail is just it's annoying, but the right and the left hilum, they have three main structures that you need to know about. So it's the main bronchus, your pulmonary vein, and your pulmonary artery. But like annoyingly, but probably as expected, they're different and they're in a different arrangement on the right and the left side. And this is a really common exam question. And so the easiest way to remember this is just the acronym RALS. So RALS is just the position of the pulmonary arteries in relation to the main bronchus. And so it stands for right anterior, left superior. So what this means is that on the right-hand side, your pulmonary arteries are anterior to your main bronchus. On the left-hand side, your pulmonary arteries are superior to your main bronchus. So if you can imagine on here, you've got your pulmonary arteries here, and then your main bronchus is basically over here. So if you can imagine, it's going to be anterior. So this is like the anterior surface, and so this is your right lung. Here it's superior, so you can see the red is superior to your main bronchus, it's on top, and so this is going to be your left lung. And it's just something that you have to remember. Faculty really like quizzing you on this, so just remember it basically. And your pulmonary veins are really easy to remember because they're always inferior. On the left side, they can be kind of anterior, inferior-ish, but it's just inferior. That's the easiest way to remember them. Alrighty. Okay, cool. So before we move on, actually, I do want to go through, there are a couple of structures that run anterior and posterior to the lung hilum, which you might want to know about. Again, it's not really that important, but I do think it was like an anatomy question. So I'm just going to go through on the left hilum, you've got like your descending aorta and your ascending aorta. On the right hilum, you've got your SVC and your azygous vein that are running on the right. And over both hilum, you've got your phrenic nerve, and you've also got lymph plexuses around them. Okay, cool. So this here is really ugly, but the good news is you don't have to worry about this until, but I've just got it here for completion's sake. So your lungs can basically be split into segments. So disclaimer, there's absolutely no need to remember or memorize these segments. You don't need to know them at all. They're never going to come up. They're kind of useless, to be honest. And you're never going to be asked anything about them. The main thing that's really important to remember is via the aspiration of foreign objects. So I didn't know what that meant when I first heard it. It basically just means if you swallow something and you accidentally choke on it, where's it going to go? So this is really important. So, okay. So where the foreign object goes really depends on what position you're in. So if you're standing up, are you lying down? What side are you lying down? Are you lying down on your back? That kind of thing. There is one universal rule though. So stuff is most likely to go to the right main bronchus. And so it's most likely to get stuck into your right lung. So the reasoning is because, as you'll see on the next slide, your right main bronchus is going to be shorter, wider, and more vertical. Those three things are key. Shorter, wider, vertical are just the key things. And so if you can imagine being shorter, being wider, and being just more vertical, so gravity really helps you, means that it's easier for things to go down that way. And because it's the easier pathway, things are going to take it more often. So that's why when you're standing, if you accidentally choke on something or you accidentally swallow something down the wrong airway, it's going to go to the right inferior lobe. And more specifically, it's going to go to your posterior basal segment of your right inferior lobe. When you're supine, so when you're lying on your back, it will go to either the superior segment of your right inferior lobe or to the right upper lobe. And when you're lying down on your right, I'm not sure why, it's very specific, it's going to go to your right upper lobe. But yeah, also when you do aspirate an object or get that stuck in your lungs, you're going to get quiet breath sounds. And the reasoning is because you've literally blocked ventilation to that area. So you're not going to have any breath sounds on that area. So when you listen to it, you guys will hopefully actually have a chance to use your stats this year. We didn't, so we're all very jealous. you'll basically be able to hear like no breath sounds or reduced breath sounds in that area. So here's just that thing, and you can see on the right main bronchus, you can see how it's like angled a bit down. You can see how this area from here to here, that pink area, is much shorter than that area over here. And you can kind of see how it's a bit fatter than the left main bronchus as well. So that's really why things are getting stuck down there. All right, cool. So I know you guys have already learned about pleura, so we're going to go through this really quickly. So your pulmonary cavities, as you know, are lined by a pleural membrane. So the main job of the pleura is basically to protect and cushion your lungs. All right, so each lung is enclosed in a serous pleural sac. Those sacs contain two layers. So you've got a visceral pleura and you've got a parietal pleura. So visceral pleura is basically that inner layer that invests all surfaces of your lung. And it's actually stuck so tightly that you can't peel it off or you can't separate it from your lung. It's essentially like a second skin onto your lung. You've also got your parietal pleura, so that lines your pulmonary cavities. And this is your outer layer that lines the outside of the chest wall. Both your visceral and your parietal pleura are going to become continuous at the hilum of your lung. And yeah, that's pretty much it. And then we move on to the pleural cavity. So your pleural cavity is that space between that visceral and parietal pleura. The pleural cavity will actually contain fluid, so we call it serous pleural fluid. It's just fluid between layers, and so it's basically so that the layers can slide against each other, and it also allows for quiet respiration. So there's no like harsh breath sounds or anything. So you can imagine if the pleura gets inflamed, or like if something happens to this fluid, you're going to get quite harsh sounds when you breathe. The pleura also has another job, but it's mainly going to be, you're mainly going to talk about it in physiology, but its other job is to maintain surface tension. So surface tension is basically just what is keeping that lung in contact with the thoracic wall. So it's going to stop the lung from collapsing, and we call a collapsed lung, like I can never say, it's like atelectasis, and it basically stops that from happening. All right, cool. So we've got, we're basically going to talk about the parietal pleura in a little bit more detail. Your visceral pleura isn't really talked about that too much because it's basically second skin on your lung. So it's mainly the parietal pleura that gets a little bit more attention. So your parietal pleura has these four parts. So you've got costal, mediastinal, diaphragmatic, and cervical. So it's very similar to what we talked about with the lung surfaces as well. On the next surface, so I've got like a little bit of a description as to where they are, but I think it's just easier to see them on the next slide. So you've got the mediastinal pleura, again, where you'd expect it, diaphragmatic on top of the diaphragm, as you'd expect, costal near the ribs, as you'd expect, and you've got your cervical up the top, and it's really cute up the top. Another name for your cervical pleura is also your cupola, which you might have heard of. It's just a weird name. I don't really know why. It's just, you just have to remember it. Sometimes you'll see it around. What is really important to know about the pleura is that they all have like, depending on what part you're at, the parietal pleura will all have a different pain distribution because they're all going to be innervated differently. So in this table, you can find like what their innervation is, and the dermatomes of the areas in which like the pain from a specific area can like basically go to. So for example, your costal pleura will go to your T2 to T10 intercostal nerves, and it will mainly present with chest pain, versus your diaphragmatic pleura is quite weird. So the central part of your diaphragmatic pleura will basically follow your phrenic nerve, and your intercostal nerves will be the peripheral portion of your diaphragmatic pleura. But basically just follow this table, and that'll tell you where the pain distribution is. Again, we don't really talk about the visceral pleura, and you won't see a similar table for your visceral pleura because it's kind of boring. It's not sensitive to pain or like temperature or anything like that. It can only detect stretch, so it's quite boring. All right. This again is a really important table that you basically have to know. So this is a comparison between your pleura and where the lungs are. So faculty love asking questions about this, and it's all about basically this table over here, which is pretty easy, I guess, once you like see the pattern. It's pretty easy to get it. But the main takeaway is that your parietal pleura will always extend 2 spinal levels below your lungs. So for example, if we go to the mid-clavicular line, you can see that the lungs will end at T6, and your parietal pleura, on the other hand, will end at T8. So you can imagine that there's a space here for things to basically come, for things to build up for like fluid or anything. But also if you want to put a needle into your pleura to get out like fluid, you can basically use these to make sure you don't accidentally just shove a needle into your lungs, that you're just shoving a needle into the pleural space instead. Alrighty. So let's keep going. So we can move on to what we call the tracheobronchial tree. Tracheobronchial, I can't say that word, whatever. I'm very tired. This is just like the branching of your airways. So your tree will begin at your larynx and it's going to extend inferiorly into your lungs as bronchioles. So as you can see from this image, as your branching is increasing, so you can see that it started off pretty big, but as you've increased, your everything gets smaller and smaller. So the diameter of like your lumen just decreases more and more. Okay, so although it starts at the larynx, the main or the very first thing that's really important in respiratory anatomy is your trachea. So your trachea arises from C6 and it's continuous with the larynx. So if you can imagine here, here's your larynx and here's the trachea, and basically it's coming out around C6 over here. This whole thing is around 12 centimeters. And it's going to be, if you can kind of see these weird like gray things, but it is basically C-shaped hyaline cartilage rings. And these rings or these cartilage rings are all about preventing its collapse. That's all the purpose of these rings are. Also, you can see over here that it bifurcates or it splits into two. So it's splitting into two at this place that we call the carina. And it's basically this space. You need to remember it because it's really important. This is the sternal angle at T4 or T5. So as you can see from this image, the trachea has basically split into you've got two major branches. So you've got the right main bronchus and you've got your left main bronchus. And then the right and the left will split further. So they will split into intermediate branches. So they first split into lobar bronchi or your secondary bronchi, and then they split into segmental or tertiary bronchi. After your tertiary bronchi, you've just got your terminal bronchioles. And bronchioles are where you've started to get distinction in the walls because bronchioles do not have any cartilage in their walls. So they're pretty frail and easy to collapse because of that. Your terminal bronchioles are going to give rise to respiratory bronchioles. So as you can see here, terminal bronchioles to respiratory bronchioles. And the respiratory bronchioles is where stuff gets interesting because this is where we start what we call the respiratory zone. So from here downwards, we have the respiratory zone. So the respiratory zone is where you've got gas exchange, and that's where like oxygen and carbon dioxide start to exchange, and the blood becomes oxygenated via the incoming air. So everything from the trachea up until the terminal bronchioles is what we call the conducting zone. So the conducting zone is just like a tunnel system for air to flow through. So it's nothing that interesting that's happening until we get to respiratory bronchioles, conveniently named for the start of the respiratory zone. All right, so your respiratory bronchioles will go into alveolar ducts, which go into alveolar sacs. And around this area, they're all about alveoli. So pulmonary alveoli are going to be the basic structural unit that you have, and they're the basic structural unit of gas exchange in the lungs. They're separated from each other with this like septum. Don't really need to know. It's just like a random lining, which has like elastin and a bunch of like other connective tissues around them. And it's just a single layer between them. Also really cool is that you're going to develop new alveoli until you're like 8 years old, which is really interesting. So after 8 years old, you don't really have any more new alveoli, but until you're 8, new ones will keep coming up. Okay. So what's really interesting, or what's not really interesting, and what you have around the alveoli, so you've got two main types of cells that are lining your alveoli lumen or the alveoli airspace. They're both called pneumocytes, but these pneumocytes are split into two. So you've got type 1 pneumocytes and you've also got type 2 pneumocytes. This will be covered a bit more in physiology, unless you guys have already done it before, in case you already know everything about them. But type 1 pneumocytes are responsible for gas exchange. So they have really long cytoplasmic extensions, which pretty much extend like really thinly over your alveolar wall. And this whole thing is basically to allow for maximum space possible for diffusion to occur. Because you can imagine if it's responsible for gas exchange, you want to have a lot of surface area for your oxygen and your carbon dioxide to basically exchange between each other. Your type 2 pneumocytes will secrete a chemical called surfactant. And what surfactant is, or what its purpose is going to basically be covered more in physiology. But yeah, it's just more compact and it's just different in terms of that. So you can see this type 2 pneumocyte is more circular and round, versus your type 1 is this huge thing over here with like these long cytoplasmic extensions. Okay. This is just a slide that's just going through the layers of what you would pass through when you go from the air or the lumen of like the alveoli to the blood. Note that this is going to be super thin, even though it kind of looks thick in this diagram, but like it will be super thin because your air needs to diffuse through this quite quickly, so you don't pass out and you don't get hypoxia. All right, I won't spend too long talking about lung vasculature because it's not really worth the time. But the only thing that I will say is that this was a point that was brought up in imaging a couple of times. So you might see it in like x-rays. And I think it was like a CT angiogram that they tried to get us to understand that the pulmonary arteries and the pulmonary veins are not going to take the same route. So they look really similar, but they're not actually exactly symmetrical, which is really annoying. But the main point to remember is that the main differentiation is that in your right lung, it's happening in your right lung, that's where the difference is. And your middle lobar vein is going to travel with the right superior vein. So you can probably try to find it over here. But in the same right lung, your middle lobar artery is coming over off the inferior lobar artery. So the middle vein will travel with the superior vein, but your artery, so the middle artery is coming off the inferior artery, which is really annoying. But it's a really small difference. Imaging really highlights it. So I'm sure you guys will also get to see it if you guys get to do dissection this year, which I'm also very jealous that you guys get to do. All right, so we'll move on to the lymphatics of the lungs. So there's a common pathway that's just written over here that lymph usually follows. And so you can go through them on this slide. I've seen a couple of like PACA questions in anatomy, if you guys still do PACA, that come up about this. So you might like to commit this pathway to memory. But not just the names, like know where they are. So you know that like over here, you've got your bronchopulmonary lymph nodes. Over here, your tracheobronchial. Over here, you've got your paratracheal. So like know where they are on the lungs. So that it's just easier to remember because they all basically go from down all the way to up. They're all making its way up eventually into the venous system. So they all kind of follow this really nice kind of pathway. So if you can imagine where they are on the lungs, it'll be easier for you to basically just like remember them other than just memorizing names via like trying to like put them into Anki or something like that. So as you can see on this slide, your tracheobronchial lymph nodes are literally located around your carina. So they're around that bifurcation of the trachea. So if you get like swelling, or if you get like a bunch of like lymph nodes that are getting like swelling, and there's like a lot of like mitosis of lymph cells and proliferation of lymph cells inside this tracheobronchial lymph nodes, you can imagine that this carina is going to be widened, or it's going to be spread out a lot more. And you can actually detect that on a chest x-ray. So over here is a chest x-ray. And so if you get widening of the carina, it basically means that you probably have a carcinoma of like the lung area. So this is just an interesting clinical point that was brought up. All right, so I'm not going to go through the next slides. The next slides are basically Izzy's slides. I think Izzy's in the Zoom, so you can say hi to her. But the next few slides are basically Izzy's slides from last year. So just listen to Izzy's recordings. If you have any confusions or questions about them, just pop them into Curious Cat, or you can just email or message one of us. So we'll just go through them because you've already done this in year one, so it's not that worth me spending time on them. But thank you to Izzy for letting me pop them into the PowerPoint. Again, the next few slides are for histology. So you'll find them onto the link that we posted a couple of days ago. Note that all the slides that I have, they're going to all be labeled, and I tried to basically put like markings onto them so you can like easily see where the arrows are pointing. Histology, again, as I said, it's not that important. We didn't get a single question on it last year, so it's a bit annoying because you spend so much time trying to memorize all these things. And I think I've only seen like 2 histology questions come up in past exams as well. And I did like 10 years worth of past exams. So it is what it is. It's not that high yield. All right, what is interesting is your clinical pathologies. So the following is going to be my attempt to get most of the relevant clinical cases and clinical conditions that you guys might come across, that you guys sometimes have to cover in like your sessions in anatomy as well. But again, it's not an exhaustive list. So I do apologize if there's like things that I've missed. If that's the case, feel free to like shoot me a message on Facebook or like on Curious Cat or whatever. And I would like update the slides if you really want like a particular condition or anything about pathology that's not already here. So we'll start off with asthma, which is probably one of the biggest ones that you're going to be covering this year. It's also an ICL topic, so it is pretty big. You do have to know a lot about it, especially about its pharmacology, like especially about how to manage asthma. That's a really big thing. So asthma is basically a chronic inflammatory disorder, and it is reversible, and it's going to be resulting in reversible bronchospasms. So bronchospasms are basically airway airflow obstruction. It's associated with airway hyperresponsiveness and can involve like immune-mediated changes. And these changes are occurring basically in response to endogenous or exogenous stimuli. So regarding the pathophys, most of the changes are due to this airway hyperresponsiveness. So basically a normal allergen like pollen or dust is going to present inside the respiratory tree, and it causes an overreaction by your immune system. It'll be gone through in immunology, but the overall message is that there will be eventually, you're going to get remodeling that will lead to airway obstruction. So these are the ways that you're getting remodeling of this. So basically you're going to get induction. So that's the acquisition of the allergy to whatever allergen that the body decides to overreact to. You get inflammation via the immune system, airway remodeling. So this can involve like hypertrophy of smooth muscle. So you can imagine the smooth muscle gets bigger and more, there's more of it as well. And so your airways, the lumen diameter gets thinner and thinner. So you're starting to create this obstruction. But on top of that, you also get constriction of this smooth muscle. So again, you're just like reducing the blood flow, reducing the airflow through your lungs. But yeah. All right. So most of the rest of asthma, because asthma is really common. So a lot of it is quite easy and quite, I guess, self-explanatory. So things like your clinical signs, triggers for asthma, all of them are quite easy to remember. So I won't spend too much time on this. So I'll move on to COPD. COPD is super similar to asthma, but it's instead, so asthma was reversible. So instead, COPD is irreversible. So this is the main and biggest key difference that I want you to remember if you take nothing else away. But it is quite similar to asthma in terms of it is progressive, but it's irreversible, and it's characterized by chronic obstruction to airflow. So patients are going to, or they can present with like exacerbations, they can present with like lung hyperinflation, and sometimes even weight loss. But it's actually like, it's quite a weird thing, but COPD is actually 2 conditions that are grouped under the one heading. So it's chronic bronchitis and emphysema that are basically grouped under the one heading. So pathologically, chronic bronchitis is just a productive cough usually. Emphysema is the dilation and destruction of air spaces, which are distal to your terminal bronchiole. But there's no like fibrosis, which is just like the breaking down of like the fibrin and everything, or the connective tissue. But those are the 2 main things. And the biggest risk factor for COPD that you need to remember is smoking. So when you have like a smoke, or you have like any question, you're like, or any patient that comes in and they just have an extensive smoking history, you need to think about COPD, especially when they're presenting with like shortness of breath. In terms of other physical findings, other than just shortness of breath that you're going to find with COPD, you'll have things like there's a lot, but the most important ones are a barrel chest. You'll get hyperresonant lungs with early inspiratory crackles. For now, that's just like a random phrase that you just remember, but you will learn more about what crackles are and everything in just like in when you do clin skills. But they're basically just an additional lung sound that you can hear. And it's basically caused by like this harsh airflow through your lungs. And the majority and the rest of the signs are mainly due to the lack of oxygen and to periphery, so like cyanosis, your wheezing, your I can't say that word. But your chronic cough is related to the chronic bronchitis. So remember, chronic bronchitis was all about that coughing. And it's also, it's especially quite pronounced in the morning. All right. So we then move on to pneumothorax. So pneumothorax is just the presence of air in the pleural cavity. Remembering pleural cavity was just that space between the visceral and parietal pleura. So pneumothorax can either be spontaneous or it can actually arise with trauma. So importantly, to note, just a very big thing that they like to bring up is that if the air is trapped inside this cavity and it can't get out at all, we say that we've got attention pneumothorax. So attention pneumothorax, you would actually treat attention pneumothorax different to how you treat a different or any other pneumothorax. So I won't go through the pathophys because you do need to understand about lung pressures, which will come up in physiology. But if it's too hard or if you can't understand it, even after covering phys, let me know. Okay, cool. So we've also got, I just popped in a table for what can cause tracheal deviation away or towards a lung lesion. So as we said, we've just talked about tension pneumothorax. So if you can imagine in a tension pneumothorax, you've got the buildup of air inside this pleural cavity. So this pleural cavity is expanding with air that's unable to leave. So you can imagine that the trachea is going to be pushed away from where the problem is or where the issue is. So you get deviation away from the side of the lesion. However, if you have a lung collapse, your lung is just collapsed, and so the trachea is more likely to actually be pushed towards where you've got that issue. So you've got deviation towards the side of the lesion. So just based on where it is, you can basically figure out kind of get what kind of issues this patient might have. All right. The next thing that we have is obstructive sleep apnea. This will again be another one of your ICL cases. So you guys will learn this in quite a lot of detail. But basically, it's a condition that's defined by episodic periods of decreased airflow during sleep. So it's predominantly based on a set of clinical features. So these clinical features that it's based on are usually persistent snoring. So often patients will say oh, my wife or my partner complains of snoring, of me snoring really loudly during the night. You have insomnia. You can have gasping during the night because you can't breathe. So you literally wake up not being able to breathe and having that gasping sensation. And because of the insomnia, because of not getting good night's sleep, you also can get daytime sleepiness or persistent fatigue. If we're going to be strict or more strict about how we're going to classify what OSA is, it can be defined as having more than 15 apneic episodes per hour every night. So these episodes are just where you literally stop breathing for around 10 seconds. So it is quite scary. But in terms of pathophys, we've obviously got that obstruction of the upper airways. So you stop breathing for that 10 seconds. And this obstruction usually comes about, typically these patients are overweight. They have a really large pharyngeal tone, and they just have a really small, they can have a high arch palate. They have just really small, just a small kind of area over there. And they basically have obstruction mainly during sleep. So during the day, their pharyngeal muscle, it's the upper pharyngeal muscle, the tone of that muscle will be maintained and it will keep the airways patent. But when you sleep, as you can imagine, you're getting more relaxed. And so this muscle tone is lost. And so the pharynx becomes vulnerable to collapsing, especially at the start of inspiration. So when it collapses, it will basically obstruct airflow. So you get that cessation of breathing, and you basically get led into the symptoms that we've just talked about. All right, so that's all that. So then we've got pleural effusions. So pleural effusion, as a pneumothorax, which is build up of air, pleural effusion is just a buildup of fluid into that pleural space. There's nothing too important or too interesting, I don't think, in terms of mechanism, because it's literally just fluid building up into that space. But there are a couple of signs and symptoms which are really important to know, which are written over here. So the signs and symptoms. So most of the time when you get faced with a pleural effusion, it will be on a CXR. So a lot of the signs and symptoms are literally from a chest X-ray. But otherwise you can have productive cough, You can have stony, dull percussion. So percussion is when you basically like go like this and you tap on their hand, you tap your middle finger and you get like this really cool kind of sound. And you will have, usually the lungs are meant to be resonant. So when you tap on your lungs with percussion, you're meant to have like a resonant or kind of like a airy kind of sound, because the lungs are only filled with air. So there's nothing to tap on. But when you do get fluid buildup, you start to get dull percussion because of that fluid is basically causing that dull sound. And it's stony because that fluid is straight underneath your skin, right? It's between that pleural cavity, in that pleural cavity area. So it's also like a stony percussion. We also get meniscus sign. So meniscus sign is just literally this thing over here. And like the pleural effusion will literally just present as like a meniscus kind of. And we will also hear like a friction rub. Okay. All right, moving on. So we get a pulmonary embolism. You guys have talked a little bit about this as well last year, I believe. And a pulmonary embolism is literally just the lodging of like a blood clot in your pulmonary artery, arterial tree. So this will lead to an increase in pulmonary vascular resistance. And you might also get like reduced pulmonary blood flow because you've got like this massive clot just stopping blood or anything from getting through. That clot usually begins in your leg, and usually in the proximal leg, so usually in like your popliteal, your femoral, or your iliac veins. But then over time, when with stress and things like hypertension can really exacerbate this, it can like dislodge into the pulmonary circulation, and then through the circulation, this vein, as you can imagine, it's traveling towards the heart, and through the heart, you'll have your pulmonary arteries very close by over there. So it can dislodge into that pulmonary circulation. But the main takeaway for PE is Virchow's triad. So these are three things which are basically huge buzzwords for this condition. So three things which are risk factors for this condition. So you've got hypercoagulability. So basically like drugs can cause this. You've got stasis, which is like sitting down or not being basically very tired, like just being very still for a very long time. And you've also got endothelial damage. So a really typical presentation, especially that they like giving you in exams, is like after someone's in like a long airplane journey, and that patient has just been sitting in their chair and sitting in their seat for a really prolonged period of time, and then they suddenly get like a DVT, or they suddenly get like PE kind of symptoms. Another kind of really common scenario is a couple of weeks after surgery. Your patient is going to be immobilized from surgery, not moving around a lot, still recovering. So they're really basically just prime candidates for DVTs and so PEs to basically form. Okay, let's keep going. So the next thing that we're going to move on to is bronchiectasis. So bronchiectasis is just the irreversible dilation of airways, and it's mainly due to inflammatory destruction of those airways. And they result from like persistent, or they result in like impaired mucus clearance and infected mucus lines. And this will eventually just affect the medium-sized airways the most, and results in the destruction in both your muscles and the elastin in this airways. In terms of clinical signs and symptoms that are important for you, I'd say hemoptysis, recurrent pneumonia, so recurrent like just infections, and as you can imagine, because you can't clear away this mucus, you're just going to get more and more lung infections that are more recurrent. Local crackles and chronic cough is really just key for this condition. All right, next is cystic fibrosis. We're going to cover cystic fibrosis in a respiratory context. This will come back when you do GIT, and you'll have to look at its effects in the gastrointestinal system in like 3 or 4 weeks. But for now, we'll only focus on what happens in the respiratory system. But CF is basically an autosomal recessive disorder. It involves chloride transport dysfunction, and it's mainly due to a mutation in your CFTR gene. So this dysfunction in this gene is going to lead to thick secretions from your exocrine glands, and these secretions will end up blocking, blocking these secretory ducts of these glands. In terms of like important clinical features, it usually results in really severe lung disease and recurrent chronic lung infections. So in childhood, Staph aureus is the most common, But in like adulthood, you get another P. aeruginosa, I can't say it. That's also really common as well. Otherwise, you can also get like an expiratory wheeze. You can also get shortness of breath, and also you can get like just like clubbing and like chronic hypoxia just from not being able to breathe enough oxygen into like the rest of your body. All right. So we also have pancreas tumors. I believe you guys may have come across pancreas tumors last year. It's essentially just a tumor at the base, at the apex of your lung, sorry. And they have effects where they basically affect the sympathetic nervous system due to pressing on the nerve roots that travel in that area. The main kind of takeaway is Horner's and Pemberton sign. So Horner syndrome is a triad of meiosis, ptosis, and anhidrosis. These are really weird words. What do they mean? Well, meiosis is just an excessively contracted pupil. Ptosis is the drooping of your upper eyelid, and anhidrosis is the lack of sweating. So this triad of these three things signifies Horner syndrome. And Horner syndrome basically means that you have some sort of pancreas tumor, or you have some sort of apical lung tumor or carcinoma in that area. You can also have Pemberton sign. So this tumor might actually grow to the size where it will actually be a mass that like compresses on the SVC, or your superior vena cava. So Pemberton sign is when you raise your hands above your face, it can it will, and you get the patient to like hold their hands above their face for around 30 seconds, and it actually causes like a redness in their face. And this is because the tumor is compressing against the SVC. And so it's basically stopping blood from going from the face back down to the basically the right atrium. And so because you've got that buildup of just blood that's trapped, basically, you're going to cause the redness of the face, and patients will tend to get like really short of breath and everything and struggle to breathe. There are a couple of more conditions on here, but they're not that important. And they're mainly, I just popped them in because they came up on the CIP. So if you remember what a CIP is, it was that really weird puzzle thing that like you only have to get above 80% and you get like 100% of the marks. But come CIP, feel free to like panic and use these slides if you want to. Alrighty. Here's just some buzzwords that come up in exams quite a lot. So just have a look at them, and because let's be real, year 2 is all about buzzwords. So all of pre-clin is all about buzzwords. So it is quite important that you do know them, I guess. All right. So we have a couple of anatomy questions. I'm not sure if we have time to go through them. So I might just skip them at the moment because the answers are right on the slide. So I'll just keep going through. Oh, actually, we'll go through them because I did go through anatomy. Let's see how much engagement we have. Let's see if any of you guys are still awake. So anyone want to just pop in the chat what the cartilage is? What's the structure that separates the right and left main stem bronchi? Anyone remember? Hey, yeah, easy. Yeah, it was the carina. So the carina is that thing where the trachea will bifurcate, and that's where the trachea will turn into your right and left main bronchi. All right, one more thing. So you've got a stab wound that's superior to the right clavicle. So the clavicle, remember, is that collarbone over here. So what's superior? What part do you think is going to be superior in terms of the pleura? And we're mainly talking about just the pleura in this case. So it'll probably be the parietal pleura in this case. But what part of the pleura is going to be cut or torn? Any ideas? Yeah, the cupola, which is also known as your cervical pleura. Yeah, easy. Okay, so this is something that I haven't talked about, but you might have heard about it quite a bit. What nerve? There's a key that like faculty always love, but what nerve do you think is going to be affected when you have like an affected or irritated kind of tracheobronchial lymph nodes? Again, remember the tracheobronchial lymph nodes are near your carina or near that like bifurcation of the trachea. So any ideas? Yeah, left of the RL N. This nerve is basically like the key for anything. If you're ever confused about anything, it's usually going to be D. And if you have a look at the left recurrent laryngeal will actually basically just slip underneath, and it slips underneath like the aortic arch, and the aortic arch is super close by to these tracheal bronchial lymph nodes. It's basically like right in front, right anterior to the carina. So it's right anterior to these lymph nodes. So when these lymph nodes are enlarged, you can basically compress against this nerve. So you get hoarseness, which is like the key thing that faculty really want you to remember. All right, cool. All right, so we've finished all that and come to probably what everyone's least favorite subject, which is microbiome. So rest micro is split into two. So you've split it into upper and lower respiratory tract infections. No one really likes microbiome, let's be real. And going through all of them are a pain, especially when like only one thing or the tiniest thing comes up. So I'm just going to say you guys can basically go through this in your own by yourself, go through all of them. I've just chosen one condition from both upper and lower respiratory tract to focus on, so we can quickly go through these, and then hopefully you guys can just go on your way. So the first condition that I've decided to basically focus on is strep throat. So it's come up a bit in past exams, so I thought it'd be interesting to highlight it to you guys because it's come up in exams before. And the most common multiple choice exam question that you get from this is asking about its complications. So as you can see, it's got both pus producing, which we call suppurative, or non-suppurative complications. And it's really important to know what these are, because questions where like it's like, what of these is not a suppurative complication of strep throat have come up in multiple choice exams in the past. So it's really important to know this. In general, your strep throat is just like the bacterial infection of the throat area, usually by your group A beta hemolytic strep bacteria, or you might have like heard it as gas bacteria. All right. So the last thing that we're going to talk about is the one lower respiratory tract infection that I chose, which is pneumonia. So pneumonia is quite high yield in terms of like just for microbiome in general. Everything else is kind of like whooping cough or like Coxsackie virus, things that no one's really heard of. But pneumonia is just a series of infections of the lower respiratory tract, and it causes inflammation of your lung parenchyma or your lung cells. So it can either be bacterial, fungal, or viral. The main ones, so faculty only talk about bacterial and viral. Fungal isn't really mentioned, but it's important to know that it is a thing. You've got community acquired pneumonia, or CAP, and this is the most common type of pneumonia that you're going to have. And CAP just means that like community acquired, as you can imagine, is just pneumonia that's going to develop without exposure to hospitals or any healthcare services. So CAP can be further divided into, you've got typical and atypical pneumonia. So typical pneumonia depends on pre-existing risk factors. And it can be caused by like a number of different bacterial organisms as well. So the pre-existing risk factors were things like having COPD, being an intravenous drug user, having cystic fibrosis. But in terms of just in general, for the general public, the most common organism for typical pneumonia is S. pneumoniae, very handy named. But yeah, most of these organisms are susceptible to penicillin. And this is really important because atypical pneumonia, which is basically caused by other kind of random organisms, all have a really poor response to penicillin. So if you're going to treat an atypical pneumonia, you can't give them penicillin. You have to look for more specific drugs and other treatment options to resolve it. What's also where the money is in terms of like what the difference between atypical and typical pneumonia is about the symptoms. So if you can see that typical pneumonia has the abrupt onset symptom, it will have a fever, you'll have sputum, and you'll have coughing. On the other hand, atypical pneumonia, you won't have any sputum at all. You only have a dry cough, and it's not like abrupt onset or anything like that. It's also got like very few physical exam changes, which makes it quite annoying. But the diagnosis of typical pneumonia, so on the x-ray, you get this very typical lobar pattern, whilst on atypical pneumonia, on x-ray, you get like an interstitial kind of pattern in terms of there. All right, so viral pneumonia, I'll just skim through it very quickly, but it's just caused by viruses such as RSV or parainfluenzae. And these symptoms are really, really similar to atypical pneumonia. And yeah, that's pretty much it for today. Cheers for coming along, guys. This is pretty much it. If you've got any questions, feel free to just pop them in the chat or to go to Curious Cat. We will put up the link unless it's already been put up in the chat before. Good job. You guys are already halfway through RESP. I know it's like only week 1, but RESP only goes for 2 weeks. So congrats on going through.